So Dr. Ishaq is a pediatric palliative care physician trained in Hyderabad in MNJ Institute of Oncology. And he's been actively working after that in Chennai, in Apollo Hospital. And he's currently in Mumbai working at the Comprehensive Thalassemia Center and bone marrow transplant in Borivali. And Dr. Mansi Patil is is a pediatrician, also pediatric palliative care physician, trained at Tata Memorial Hospital in Mumbai. And she's currently working with me at Royal Hospital for Children. So over to you, Ishaq and Mansi, to speak about palliative care emergencies in children.
Thank you, ma'am.
Thank you very much, ma'am. So I think we'll jump right into it. And thank you very much, Veronique ma'am and Dr. Kalra, for a lovely introduction and a beginning to this session and setting the tone. As you both already mentioned, that we want to work in tandem with oncologists as much as possible. And when we first read this topic of palliative care emergencies, we imagined that everyone here must have already dealt with them in some form or another. But still, our aim today is to provide a bit of palliative perspective to all these emergencies and see how they align with goals of care in advanced disease rather than during treatment. So I'll proceed to the first slide. Yes. So for what is a palliative emergency? It is an acute event causing severe distress or rapid deterioration. What we aim in palliative care and in general is rapid comfort and relief of suffering, right? And as I said before, aligning with the treatment with goals of care. I'll come to details later. But one of the main things that we deal with when we are handling these emergencies is to make sure that they are aligned with the advanced nature of that cancer at that point, as well as the non-beneficial or burdensome interventions, to make sure that we are not getting into those because of out of practice or our general approach towards these throughout treatment. So there needs to be that little bit of a reframing that has to happen. So coming to what are these common emergencies? Today we'll be speaking about severe dyspnea, delirium, catastrophic bleeding, SVCO, and spinal cord compression. But there are other emergencies like pain crisis, seizures, raised ICT, and terminal secretions. So moving on to our first symptom today for the day is dyspnea. So what is dyspnea? Let's try to understand the prevalence of dyspnea in pediatric palliative care, to identify approaches in managing dyspnea, and also a bit of use of opioids when we are managing dyspnea, which might be new as a concept to some of you over here. Okay, so before we start, can I please request everyone to spend the next 20 seconds in just holding your breath. Just hold your breath for 20 seconds, everyone. Okay, you can relax now. Anyone wants to unmute and tell me if they felt anything during this? Feel free to just unmute and say how they felt or put it in the chat, if at all. Okay, since no one's volunteering, Dr. Ishaq, you want to tell us how you felt?
So, so it felt as if there was air within my chest. I'm not able to breathe out, though it felt unsettling, uncomfortable feeling was there. I knew that, okay, in 20 seconds I'll be able to leave my breath out. But then again, during that period, it was very unsettling.
Okay, thank you so much. So yeah, so the main thing that we need to understand when we are dealing with dyspnea, especially, is that it is a subjective sensation, right? And it has become something as a symptom, which is an uncomfortable awareness of breathing. So not necessary that the physical abnormalities like hypoxia, drop in saturation, or respiratory rate might necessarily not match the amount of dyspnea or that subjective sensation that that child is facing. And a person's perception of dyspnea may have no relation to their appearance. For example, they may be breathing very rapidly and they may not be short of breath, but at the same time, people who are comfortably breathing and slowly breathing might also feel very breathless, right? So that's a big difference and something to understand when we are dealing with dyspnea. Um,
Mansi, you want Vinila to share the slides for you, otherwise?
Hello, ma'am, we lost you.
Vinila, do you have her slides, Vinila?
No, sir. If you have, can you just forward? I can just download in 1 minute. Meanwhile, you can just keep talking something, sir. I'll just connect back to madam and then revert back. Just lead the discussion, sir, meanwhile.
Yeah. So like Dr. Mansi was saying, dyspnea is a subjective feeling. And many a times whenever we want to even think whether the child is dyspneic or not, it is always good to ask the child rather than just looking at their respiratory rate. And there are many components to it why dyspnea comes. For example, it could be because of either underlying causes, or it could be because of any kind of medications leading to that, or it could also be because of progression of the disease. Are you able to put the slides on, Vanilla? Because it'll be easier.
I don't have them as backup, sir. So that's the only problem. I'm just trying to call.
Okay.
Do you have them with you, sir? Any chance?
Yeah.
If you have them,
Yeah, Ishak, you can take.
I'll send it across to you.
yeah.
Sorry everyone for this glitch.
Ishak, you're not able to share yourself? If Vanilla gives you sharing rights?
I'll just forward it, ma'am, because again, if the slides don't play up, Vanilla, I'm just sending you the slides.
Yes, sir. By WhatsApp or email?
I'm emailing it to you.
Yeah, no, just want to keep everything ready. Open the mail and keep ready.
Vanilla, I've sent it to you.
Yeah, yes, sir.
Mansi is just entering the room again. I've just admitted her.
Yeah, anyway, I'll just be as backup.
Yeah. Because she got disconnected.
I'm so sorry for this.
Welcome back, Mansi. No issue.
Vinila, your share. I'll share again, right?
If you're comfortable, you can share, ma'am. I
Yes,
will
yes,
also just
yes.
be as
Just
backup.
a
You can
minute.
start
Yeah,
your
I'll share.
discussion.
I'll share.
Yeah.
So till Dr.
Yeah.
Mansi is sharing, yeah, okay.
No, go ahead,
Yeah.
please.
No, go ahead, Mansi. I was just asking if they have seen dyspnea as something pretty often in their setting of cancer.
Okay.
Please go ahead.
Okay. Thanks for taking this up. Sorry, very sorry for my connection loss. So as I was saying that it's a subjective sensation, and what we need to assess or understand in pediatric palliative care, and I'll be saying PPC after this, is that when a child is particularly facing a symptom, what we need to do is objectively understand how the child is feeling because of it. So what we basically focus on in PPC is the subjective sensation of that person rather than the parameters that the child has, right? So this might also be associated with a lot of anxiety. And as we say, the concept of total pain might have already been discussed earlier, but this also applies to other symptoms where in spite of that being a physical symptom, there are multiple other uh, uh, aspects to every symptom that a child is experiencing in advanced cancer, and those may be psychological situations and aspects like why am I feeling dyspneic? Suddenly I was breathing well. Is my cancer coming back? Is it increasing? Has it entered my lungs? This applies also to the family wondering why their child was doing well and now is suddenly breathless. There can be social issues where the whole family and the people around them have started wondering why the child is not doing as well as he was before. So not only does this add to the anxiety, but it also adds to the overall experience of this symptom that the child is experiencing, which might not be so similar to in our oncology inpatient settings. Right. So in dyspnea, basically in PPC, some of the main causes that we see are disease related because of the tumor burden or the cerebral tumors are increasing. They're compressing on the medulla. There's airway obstruction, definitely involvement of the chest with the pleural effusions, left ventricular failure, these kinds. Then there are central causes. I don't need to go into much detail because we all and you all must have seen this during practice. But the thing to understand that it is multifactorial dyspnea when we talk about advanced cancer, because it can be something right from anemia or sepsis or acidosis or the whole tumor increasing and that increasing the entire experience of breathlessness. And this overall experience is escalated because of the psychological aspects like anxiety and panic. So coming to assessment, what is most important right now is to see whether there is an immediate reversible cause that can be removed and whether it aligns with the goals of care. So let's give you an example of someone who's in advanced cancer. Suppose it's an Ewing sarcoma with lung mets, and now you know suddenly that the child has started experiencing breathlessness. So this could be related to the anemia that the child has started. There could be pain that has started because of the bone tumor. It could just be frank lung mets that have developed and they slowly developing pleural effusion because of that. There can be other thoracic changes that are happening because of these uh, lung involvements and many other. So what needs to be done as a first step is an assessment of what can be reversed out of this and what may not be reversed. And our entire communication after that with the family depends on this. So for management of dyspnea, like I said, evaluation. For evaluation, what do we do? I just wanted to quickly talk about the Dalhousie scale over here. And you can see that there are 7 pictures that you can observe here. So right from chest tightening to throat, feeling a sensation of throat tightening, to exercise fatigue, to respiratory effort, and your legs feeling the effort of that dyspnea, you get a score from 1 to 7 and you can grade it accordingly, and severe dyspnea, mild, moderate and severe. So initially when you're dealing with a child, the first thing that needs to be seen in advanced cancer is to make sure that the child is not in pain, because pain most often is very commonly linked to dyspnea. You can see whether an anemia, if it aligns with the goals of care, whether it's possible to give a transfusion at that point if anemia is the reason and it's a reversible situation, or there can be fluid overload, there can be anxiety, fatigue. These will need more of in-depth help and support to the patient as well as the family. So coming to underlying causes, so when we are treating this, Bronchodilators for bronchospasm, reduce fluids, consider diuretics when you're dealing with frank creps and rails, or there can be effusions. I don't think we go into too many procedures when we are in advanced illness, but there are still some things that you can do, which is considering a transfusion. You can definitely position, treat them, teach them relaxation, use anxiolytics. So these are some of the things. And then, of course, using external help with other members of our team, where we make sure that our psychologist has had a chat with the child, ask them how they are feeling about this symptom. Can there be something that can be done to make them feel better about that situation? And there are answers that you can get, because dyspnea will be a multifactorial symptom in advanced cancer. So, integrative therapies, I don't know whether in previous sessions, I am sure someone must have mentioned this, but this forms the mainstay of any PPC illness or emergency or symptom. And most often, these provide the first layer of support when we are dealing with children with dyspnea. So, physical comforts are most important. For example, just air circulation, using a fan on the face or wetting the face with a wet cloth. These are things that are found to be very helpful when a child is in dyspnea, especially terminal dyspnea, when we are not able to provide them too many medications or take them back to the hospital, and because that does not fit in their plan. Um, there can be lowering the room temperature. You can use a humidifier. There's an ethical dimension to use of NIV over here, because NIV at the same time can be a very distressful addition to the entire experience, especially at end of life, which is the last 2-3 weeks where we are talking about. And we should be very careful when we are trying to introduce things like CPAP at home and or any other distraction. Definitely when there's a music or there's video or there's a simple mobile or family members coming in and chipping in to make sure the child is feeling a little better in that advanced illness. There is parental support. Yes, definitely 100% parental support necessary, but the parents also need support, and we cannot forget that to see their child actually suffering or breathless itself is one of a very panicky situation for them. So addressing that, just making sure that they are feeling okay about the whole thing. And then there are complementary therapies like massage, aromatherapy, and I won't go into too much detail. So just to highlight once more that we might take it little lightly, but fans have been one of the most helpful supportive therapies for dyspnea. And do try when you're next dealing with some of these patients to see the effects of fan on the face, right? So in pharmacological approaches, oxygen is again benefits versus risks. Oxygen mostly does not improve dyspnea in patients with cancer or life-limiting disease when they are at end of life. It is more of a psychological benefit both to the patient as well as to the parents and the family. And we do use it. So when we do send our children at home, they are sometimes on an oxygen concentrator just for minimal support at home. So coming to morphine in dyspnea, I don't know how many of you have used morphine for dyspnea, but it definitely is the gold standard and the first line therapy for dyspnea in advanced cancer for sure. So it acts on the mu receptors, like we know. It decreases the perception of dyspnea, and what we are trying to do here is work on the perception and the reflexive drive to breathe. So hyper-responsiveness is decreased, and a little bit improvement in efficiency for sure when the child is breathing, right? So how do we use this morphine? We typically start with a 50% of normal starting dose for pain. So for if we are starting with 0.2 mg per kg per dose for an oral administration for pain, what we would do in dyspnea would be 0.1 mg per kg. This would apply to all routes where we would start with 50% of normal. And if a child is already on opioids, then you titrate to effect. You are able to give SOS doses as well as you titrate the effect and see how the breathlessness is responding. Keeping in mind that many children are opioid tolerant and or there might be renal issues in advanced cancer, and sometimes fentanyl is used, but mainstay is morphine. Nebulized opioids have not been effective for dyspnea management, and yeah. So coming to concerns about opioids, there are many people who will say, mostly colleagues who will say, no, no, this will cause addictions. That's not the time to think about those, and it won't. It will not mask the symptoms of end of life. It will, in fact, provide comfort and care at that point. This is definitely not euthanasia. Using morphine or benzodiazepines in end of life should not be considered as any form of expediting uh, end of life. In fact, it is providing complete care to the patient. Um, and like I said, yes, benzodiazepines like lorazepam, midazolam, these are some of the common ones that we are using. We are also using corticosteroids when we know that there's an airway obstruction, or there's an obvious effusion that which is, or there's stretch pain which is causing this entire experience. You can also use anticholinergics. And for refractory distress, we'll talk about this later, but palliative sedation for extremely refractory dyspnea has been used for control. So key takeaway points for dyspnea would be it is a subjective phenomenon. Fan, never forget the fan. Opioids, definitely first line gold standard medication for dyspnea. There is absolute amazing response. Dyspnea and anxiety, don't forget that anxiety is also a big part of dyspnea and the experience of dyspnea. And all non-pharmacological approaches as well as reassurance to the patients and family. So next I'll request Dr. Ishak to talk about delirium.
Thank you, Mansi. Am I audible? Is my voice clear?
Yes.
Yes, sir.
Yeah. So before going to delirium, is there any questions for Dr. Mansi in regards with dyspnea? Anything in the chat? Anyone wants to unmute and put a question? Okay. Anyone? Yeah. Okay. Mansi, can you help me with slide movement? So a delirium, like most of us have seen in our day-to-day practice, is something that needs to be assessed properly, needs to be uh, looked into as well as treated at the earliest. So whenever we are looking for delirium, many a times it is also dependent on whether we have a high index of suspicion. Many a times I've seen my staff, even me, whenever we go to the wards and see the child at one contact and the child is not responding well or maybe just drowsy and all, we tend to not think on lines of, okay, is this something just general alertness, wakefulness, or is it something that could also be delirium? So always try to have high index of suspicion if you have a child who is in PICU for more than 5 days, or if there is an underlying concomitant factor that can lead to delirium, or if the child is less than 2 years again. So these all features are something would point to higher risk of getting or having a child go into delirium. So whenever we talk about delirium, look at the underlying etiology. Also ask yourself, is there any provocating factors? Also, first and foremost is this delirium or not? Because whenever we talk about delirium, we have a spectrum from, in coming slides will show you what are the various types of delirium. But then again, there is a spectrum where we might feel, okay, the child is just agitated, or the child is a bit combated, or the child is very dull. So it could be a complete spectrum. So try to find out what is the symptom, whether it is just usual agitation because of some other causes, or is it pointing more towards a hyperactive delirious state. Look into what are the provocating factors. Like I told you, any child who's admitted in PICU for more than 5 days can be someone who's at a high risk of going into delirium. A child who's less than 2 years is again in a high risk category. If there are factors where the sleep wake cycle is bad, or if there are any medications also. For example, like Dr. Mansi was telling, in terms of opioids, if opioids are given and not monitored properly, it can also lead to delirium. Or if benzodiazepines as a medicine is an independent and dose dependent risk factor for causing delirium. So look at what are the various medications. It could also be anticholinergics as well that can lead to delirium, and then even antiepileptics can cause a delirious state. Then the other questions to ask is, whenever the parent is telling you that, okay, this that the child is being drowsy a lot of times or getting agitated in between, try to ask if they can keep a diary of symptoms and in terms of how frequently this is happening, because delirium has a very up and down course, so it is not something that is a steady state. And try to get a video recording if there is a possibility to you to know whether it is just basic agitation. At times you might also feel, okay, is this seizure also? So try to get a video recording, ask for it if possible. Next slide. So like initially how the symptom was told about dyspnea, try to find what is the symptom, try to use a stepwise fashion for better assessment and management. Whenever you are evaluating, right from what are the risk factors to what are the contributing factors, what are the medications that can lead to this, also try to look into it. And once you have noted it down that, okay, this is delirium, try to differentiate what kind of delirium it is and look into what are the various therapies that you can do, both pharmacological as well as non-pharmacological. Lastly, whenever the parent is telling, okay, he's acting weird and all, try to know what is the meaning attached to the symptom. I've had adult patients as well as children who were told by their attenders that ki pagal ho gaya, he's gone crazy, he's acting very weird and all. Try to understand what the meaning is, because you can redirect it by saying that no, this is not what they feel it is. It is something that is related to uh, something that is related to attention or awareness, and that can be treated, because we don't want our patients' family members to feel that the patient has gone crazy or mad, right? So try to find that also. Now coming to what is delirium, according to DSM-5, delirium is a disturbance in attention as well as awareness, accompanied by changes in cognition, which can be developed over a short period of time, and fluctuates in course, and is a result of a medical condition. So you can see in this, the point is it can develop immediately within a short period of time and also fluctuates in course. So a child can converse with you uh, in a all right way, but in few hours the child might be in a confusional state. So the child can go into good mental state to something that is more in terms of uh, fluctuating awareness. And many a times this acute change can be brushed out saying that, okay, fine, he just got irritated. But then again, please have a high index of suspicion when such a thing happens. The one challenge in putting a diagnosis to delirium is variation in age development also, because whenever you're looking at a child who's less than 2 years, you need to be mindful of the developmental anchor points, because you need to know whether the child is able to comprehend what you're speaking, or whether able to maintain eye contact and all those points, because that is important for the neurodevelopmental uh, thing. As well as also there are many a times polypharmacy and precipitating factors that comes with the disease as well as the management. So that is why delirium becomes challenging to even recognize, assess, as well as treat. Next slide, please. So like we told, initially risk factors could range right from advancement of illness, it could be sepsis, it could be metabolic disturbances, as well as medications that are there during the treatment of the child, as well as any disruption in sleep wake cycle as well. And if a child is in ICU for more than 5 days or even for good amount of time, the sleep wake cycle is totally disturbed because they don't know whether it is day or night. Most of the time it is this artificial light, right? So always it is better to get them back to understanding that okay, what is daytime, what is night time. And also if there are concomitant symptoms that are not controlled, such as uncontrolled pain or distress, is one of the major risk factors for delirium as well. Next slide. So what does symptom include? Like we told in the definition, impaired attention. It's the most sensitive symptom for diagnosis of delirium. Makes you to suspect, okay, this could be delirium in the child, and then you start using your scales. Changes in consciousness, orientation, and affect. There will be changes in behavior. There could be dysfunction in cognition, perception, and language. There could be confusion in memory and orientation. They might not know where they are. That's why it is always better to orient them to time, place, person. That this is, you're in the hospital, you're in the ICU ward, telling them regarding what the time is, etc. And also whenever there is sleep wake disturbances, you have to also look into this, as well as irritability and agitation. Many a times we might feel that okay, this is not delirium, the child is just agitated or just irritable, but it could be a form of delirium. Next slide. So as you were telling, in types of delirium, you have 3 categories. One is hypoactive delirium at one spectrum and hyperactive delirium at the top spectrum. And then a child can have both of this as a mixed delirium part. You can see there is a fluctuating course of alertness, wakefulness, agitation to stupor, sedation, etc. So the child can basically move from one spectrum to another. So how do you know whether the child is in which spectrum? Based on the timing, frequency, as well as even getting to score them. We'll show you what are the various scales. Next slide. So when you are assessing delirium, the best studied delirium scales are Cornell assessment of pediatric delirium. This can be used from ages 0 to 18. You can also use pediatric confusion assessment method for ICU in children who are more than 5 years. There are other scales that can also be used, but these are the best studied ones. Next slide. So I'll just give you a brief of how Cornell assessment of pediatric delirium works. Normally, whenever you see a child in ICU or in any setup, try to get a RAS score. RAS is Richmond's agitation sedation scale. The score is from -5 to +5. Whenever the score is -4 or -5, which is deep sedation to unarousable on the scale, you do not proceed because you won't get the answers to this and you won't get a proper score. You have to ask the patient's caregiver, whether the child is making eye contact or the actions purposeful, etc. And you rate them according to the frequency of it. Suppose if the score with all these 8 items comes more than 9, this is a significant amount which you need to keep in mind. Because then what happens is you need to keep on assessing this every twice or thrice in a day. Whenever the nurse comes, you have to ask whether they can go and assess how the child is with their RAS score and also this delirium score. So based on that, you will know whether the child is in delirium or not. Basically, it can screen the child. Next slide. And then once you screen the child and when you know that, okay, this child is either high risk for delirium or is in delirious state, then you look into what are the various strategies you can use. So whenever we talk about symptom management, it is more of an integrative approach. It is not just writing a couple of medications and moving ahead. So when you're looking at this, look at how you can prevent delirium. It could be with help of removing any medications or any risk factors around it. Again, orienting the patient to time, place, person. Looking into what are the environmental things. Many a times what happens whenever the child is delirious or agitated, in quite a few ICUs, we see they are just tied to their bed. That is not helpful. Try to see if there is a bit of sunlight access. That helps because it orients them to morning and night. There are some non-pharmacological management strategies, such as looking into if there are any reversible contributors, if there are some amount of polypharmacy that is happening. Try to reduce those medications according to what is needed and what is not needed. Make family members familiarize that this is something that is treatable, this is not madness, this is something that is happening because of the interplay of so many things that are there with the child's condition. Reassure the family members that this agitation is something that can be controlled, because it causes a lot of distress to the family also, seeing their child or loved one go through this, right? Try to reduce the noise. Could be just ICU noise, you can reduce that. Try to dim the lights a bit whenever it is the night time. Try to reduce stimulation. Try to see that you don't go multiple times trying to examine the child. Have specific times whenever they are awake, it becomes helpful. And try to also introduce yourself whenever you are examining or touching the child for examination. And use some orientation aids, use some comfort objects. Also know who is the caregiver the child wants around them. So that also helps. Next slide. So that was about non-pharmacological aspects. Looking into pharmacological, I won't go into much of dosing and all, but there are two types of antipsychotics that we can use. It is atypical and typical antipsychotics. Many a times we use risperidone and haloperidol in different dosages. Try to avoid benzodiazepines if possible. Just because the child is agitated, don't keep on giving benzodiazepines up and up, because if it is delirium, there are other medications that would be better serving the purpose. And try to treat the underlying cause. If there is sepsis, try to treat it. If there is severe pain, try to see that there is good pain relief. And if the child goes into refractory agitation, then you can consider palliative sedation. Until then, try to just look into what are the other things you can do. Next slide. So this is a chart of how you can consider a trial of antipsychotic medication. Suppose if there is less severe physical illness, or there is absence of organ impairment such as cardiac and hepatic, if there is lesser agitation or aggression and enteral route is available, you can look into usage of risperidone. You can give from 0.25 to 2 in divided doses. And if it is a good response, try to integrate it with non-pharmacological aspects and keep on continuing and reducing the dose accordingly. Suppose if it is a more serious physical illness, the child is in severe sepsis, having impairment of hepatic and cardiac, a lot more agitated, and you're not able to utilize the enteral route, you would want to use more of a subcutaneous or IV medication route. The best possible drug for you here is haloperidol. And whenever there is even marked polypharmacy, try to reduce that. And you give haloperidol, have a look at the response. Again, integrative therapies have to be given. Suppose after doing this, the good response has not come with either of the medications, and if it is a poor response, look into what has been the reason, what are the precipitants that have been overlooked probably, and then you need to remove deliriogenic drugs. Like we told, it could be right from ranging from benzodiazepines to antiepileptics or anticholinergics. Try to see that you intensify non-pharmacological management and also increase the dose of the initial antipsychotic. It could be haloperidol or it could be risperidone, and you can like switch between. And during this period, you can also look into augmenting with lorazepam, and also use have a trial of psychostimulant if it is a hypoactive delirium only. So this is just a flowchart with which you can look into how you can better treat delirium through pharmacological ways. Next slide. So the take-home point for delirium is quite a few times it is self-limiting. Many a times the most that is needed is non-pharmacological management. Studies have proven that non-pharmacological management is as good as pharmacological, but then again, if it becomes more and more, then you need to go for the pharmacological management. Delirium increases the hospital stay, it increases the mortality. That's why it is so very important to see that you assess and treat it well. There is a higher chance that the child is going to be hospitalized for longer duration because of this. The screening which we mentioned, corneal assessment of pediatric delirium, it is fast and reliable, takes few minutes, and it gives you early detection. Always keep in mind what are the developmental anchor points so that you base that neurodevelopmental as well as the assessment of delirium in a proper way. Also, try to look at early detection, keep a high risk of high vision of uh, thought that, okay, if it is delirium, what are the risk factors? Because this is a single symptom that can spoil the whole outcome of the child. And whenever you treat delirium fast, it also doesn't come back so easily as well. It improves long-term cognitive outcome as well as quality of life as well. So these are some take-home points. Any thoughts or any patient stories you would like to share in this? Okay, we can take the questions again later as well. So next symptom, I'll ask Dr. Mansi to go ahead with bleeding.
Thank you. So coming to bleeding, and as oncologists, you might have come across bleeding a couple of times, of course, and have dealt with it. But from the PPC aspects, and especially let's try to imagine bleeding when someone is on palliative care and is mostly non-institutional. And that time, it can be a very distressing, frightening, and traumatic experience for the child, for the family, and everyone around them. So it matters because in advanced malignancy, hematological disease, organ failure, end of life, bleeding is sometimes one of the most common symptoms. It signals disease progression. It may be a sign of terminal phase setting in. And that is the point where goals might shift. Definitely from cure, they might have already shifted towards comfort, but it's also towards dignity and preparedness for handling this bleeding. Right. So, common causes of bleeding, as we all know, malignancy. So, if there's like a solid tumor, there's tumor erosion into vessels. There can be thrombocytopenia persistently. It can be a DIC. It can definitely be chemotherapy cytopenias, not so common in advanced malignancies if the child is on oral metronomic or something like that. And that's not something that we very commonly see, but it can be due to sepsis, renal failure, liver failure, all these other end organ failures. It can be an outcome of leukemias and thrombocytopenia setting in at end of life. So these are some of the main things that we see on the PPC side. And we also see large bone tumors like osteosarcomas or Ewing's, which have grown to proportions that have caused mucosal or a skin barrier disturbance, and now they are bleeding through that, right? So what is necessary here is to understand that when we are particularly seeing bleeding in PPC, it can be multiple sites of bleeding at once. Suppose the child goes into extreme thrombocytopenia at end of life, and suddenly there is mucosal bleeding, there is skin purpura, petechiae set in. It can be a form of hematuria, there can be anorectal bleeding, vaginal bleeding sometimes, hemoptysis very commonly in lung involvement, um, and intra-organ definitely, like what we most commonly see as internal hemorrhage is either a intracranial one or intra-abdominal is something that we deal with most commonly when we are providing home care to children with malignancies. And a catastrophic bleed, terminal hemorrhage, something that you will dread, but if you're not prepared for it, that is a point when families take one of some of the most difficult decisions and end up rushing to hospitals. There have been deaths on the way just because the family was never aware that this could be a form in which their child would pass. So just that preparedness is very important when we talk about bleeding. Um, so yes, assessment. So when I'm talking about assessment, let's imagine that we are doing a remote assessment of bleeding and trying to help this family remotely, so that we are not getting them to rush into the hospital, or at least we are stabilizing them before they rush towards the hospital. So for stability, what would be check? First thing would be a site. Next would be severity and the rate, like what is the proportion? Is it oozing? Is it very fast bleed? Is it a uncontrollable bleed? Is it a minor one? Is it something very major? Because the family is so disturbed during advanced illness that it can be something that can be handled if you get a proper assessment. And you can give immediate advice on the phone before they start rushing towards you. Of course, there are medications that can lead to bleeding, and they need to be stopped if there is a history that has been discovered. Right. So general principles when we are dealing with bleeding is something that is not very similar to what we would do on someone who's on treatment. So immediate platelet transfusions and rushing, that is not something that we would see. We would basically talk about aligning these with goals. So when we are sending a child home, for example, who is a leukemia, and we know that this child is now going to pass in a few weeks, we send them prepared with communication, telling them that bleeding can be one of the causes of why your child may pass. It could be a bleeding through mucosa or skin or eyes, even intracranial, but it would also be bleed that would keep the child awake, but it would suddenly lead to shock and hypotension because of an intra-abdominal situation. So this communication is required. And when the child is well, it is something that is not very well appreciated by parents. So it takes, I mean, you have to have a very fine balance when you're talking about bleeding, because at that point, they're already facing the news of their child having relapsed. And then you're also additionally telling them the various ways in which that child may pass. But often it's the only point of contact that you have, especially when we were at Tata, that they're sending patients away into different cities. So they have to be communicated these things so that they're prepared somewhere for them. And how do you prepare them? Because so whenever we send patients home, we make sure that we have kept tranexamic acid with them. Tablets are available with them. Gauze is available. We tell them that dark sheets should be kept handy whenever there's a child with a very large tumor or leukemias. And also just make sure that when they are going home, they are not unnecessarily checking platelet count every few days. What we tell them is that keep it based on the symptoms that the child is having. So, and also keep your transfusions aligned to those. So don't look at numbers anymore. What we will look at is the clinical picture, right? So yes, like we all know, tranexamic acid, vitamin K, platelets, FFP, these are all things that where we talk about benefit versus risk. We also think about availability, because if someone is remotely somewhere and you're telling them that just go and find the next platelet source, that might be the cause of aggravating the clinical condition rather than actually helping the child. So these are some of the nuances that come in PPC, where we cannot really give advice based on the usual steps that we have, but in fact tailor it according to the situation of that patient and their understanding of what needs to be done for their child. So whenever there is persistent bleeding and your patient is telling you that now my child is bleeding persistently, you have to reassess goals of care. There might be a need to talk about the illness once again, telling them that this is progression, this is how the child is going to slowly deteriorate. But what are we going to do for the child? One, we will definitely consider palliative transfusion when there are symptoms, and it is very difficult to tell someone with a child with leukemia not to come for these regular transfusions every now and then, but you can make it more based on symptoms and how the child is clinically rather than treat their reports. Local hemostatic packing, palliative radiotherapy in bone tumors that have. So these are some of the things that we can consider. what is predominantly required is distress relief, right? So I just wanted to talk about this quick case that we had, and this is a child with AML, infantile AML, who we sent to the outskirts of Mumbai, and they were almost 2.5 hours away from Parel, Vadia Hospital. And this is the ASHA worker and ANM that we had to involve. And we were so happy that even in that village, the primary care team played a very active role in helping us for this child. So we were very direct with explaining to them that this child may uh, mostly there might be two ways in which this child may pass. One is that there'll be anemia, there'll be hypotension, there'll be shock, and that is how she will pass. Or there is going to be a probability of a catastrophic bleed, and we will need their help. So this is what we provided them, dark towels, for because it's a very distressing symptom for the parent, of course, to see their child ooze and pass. But if explained properly, this lady who had no idea what an AML was could easily, nicely support her own baby when the child had actually bled to death. She did bleed through all the orifices. She did do some tranexamic acid, and she did use adrenaline. But those became secondary. What was most important was that the mother knew that she had to keep holding the child close to her chest. We used morphine and we used lorazepam just to sedate the child when she was getting very cranky at the end. And the rest of the community and their role was very important in helping them prevent running back towards a hospital or towards any other local places where they would not have received the care that was necessary. In fact, a primary healthcare setting could actually support them because of the communication. And so we were very glad that this could be provided at their setting. So when there is communication with the family, our focus is not on trying to scare them, but definitely we want to outline a picture of what is going to happen in case bleeding is going to be one of the features of their advanced illnesses. This is very common in osteogenic sarcomas and RMS and Ewings, which tend to grow very rapidly in the end, as you will all know, obviously. Um, but also for our leukemias, and make sure that they have the medicines that they need for that quick distress. Make sure that they know that sedation can be done if it's a very unbearable situation, definitely for bigger, older children. And also, please do talk about death, because they should not anywhere feel that because they did not address the bleeding, the child passed. They need to have it in their mind that that was their way of passing. So there's a very big difference in communication that we need to keep in their mind, because they will always hold the guilt of not taking their child back to the hospital while it was the most correct thing to do at that point. So minor bleeds, we will do local and comfort care. For catastrophic bleeds, we do rely on rapid sedation. We do rely on presence. And we also rely on community support and making sure that our parents are very well aware of what needs to be done and what is futile escalation when there is bleeding or any other symptom. Just making sure that the child is in comfort is most important during such difficult symptoms. So I'll pass it on to Dr. Ishak now for superior vena cava syndrome.
Thank you, Mansi. Any questions from our participants? Because we have discussed 3 symptoms now, and I know that all of you have seen all of these in your day-to-day practice. Any thoughts, any patient stories you would like to share with us? Any questions before we move to another symptom that is something that you manage way better than anyone in the practice? Any thoughts from your side? Okay, we'll move forward. So there are 2 more emergencies. We are going to talk about superior vena cava syndrome as well as spinal cord compression. This is something that you might be seeing at different trajectories of illness in the children whom you treat. Mansi, can you move to the next slide? So SVC obstruction or compression that is preventing the venous drainage from head, arm, and upper trunk comes under SVC obstruction. The most common reasons why this presentation happens is because of an underlying mediastinal tumor. That could be because of neuroblastoma or a lymphoma. It could be because of IV thrombus in the central line that can impinge the drainage from the superior vena cava. Many times it usually occurs over months, weeks or months, and there is some amount of time for the collateral circulation to develop. You can see in this child, the whole chest is filled with the popped up veins, right? And occasionally it can also occur acutely and also can become an emergency. Next slide. There is some symptomatology that exists whenever a child presents to us, where we think it can also be, this diagnosis is something that can easily be attained clinically also, such as many times the symptoms is because the SVC is obstructed, the whole of blood is left without proper drainage. It can lead to edema of face, arms, many a times usually bilateral. It could be worse in the morning and fluctuate over the day. There could be redness or dusky color of the face and upper chest because of the stasis of blood. There could be dyspnea because of edema that happens near the tracheal region. There could be a feeling of fullness because of cerebral edema, as well as there could be this early sign of early morning edema of eyelids. So many a times these signs and symptoms itself takes us to the diagnosis of SVCO. And like we told, whenever you see the chest region, you can see there is puffiness as well as dilated veins visible. And uh, and when it becomes yeah, we can shift to the next slide. And when does it become an emergency? When there is a rapid progression of facial swelling, dyspnea being one major reason why it can become an emergency due to airway compromise. Whenever the child presents to us with stridor or orthopnea, and there is an altered consciousness because of cerebral edema, as well as whenever there is a hemodynamic instability. It is rare, but it can be very serious as well. Next slide. So, what do you do when a child presents with SVCO? Again, like we told, it all depends on the trajectory of disease. Suppose if the child is coming at the initial stages, you would like to understand what is the etiology, go for investigations such as X-ray, CT, etc. But if it is more during the later phases, the investigative part is something you would need to look into whether it is helpful or not. If you are looking into the management, irrespective, look into whether it is at whatever trajectory, try to look into what is the position at which there is improvement in venous drainage. The position is being upright. Usage of oxygen for comfort only. If it is more in the later parts, at times oxygen might not be helpful, but if it is comforting, please continue. You can use opioids like we have told for breathlessness and even for pain, headache. Opioids, because of the various modalities of action, this is really helpful. Anxiolytics will help because they reduce the distress part, and many a times breathlessness is something of a cycle. For example, whenever there is breathlessness, the child will get anxious, and again there is breathlessness. So you want to break the cycle of anxiety part, right? So anxiolytics is something that is helpful. Try to avoid lying flat position as well as minimize distressing procedures. Look at what are the goals of care. Based on that, you can look into going better for the management. Next slide. And treatment wise, hospital admission is something that is the initial thing you would do whenever the child is in the initial trajectory of disease. Suppose if the child is at home where the child is in end of life and all, hospital admission is not something you would look into. But then again, you would look into the pharmacological as well as the medication parts. So that's why I said it depends on the trajectory of disease also when you are going to see this. because if there is a mediastinal mass, even though you're treated it and it has come down, at later phases, if there is a relapse, SVCO can again happen, right? So that's why you need to look at the trajectory and then decide. Look at starting dexamethasone at 1 to 2 mg per kg per day. The only small difference in practice from PPC and oncology treatment is we normally tend to give a single dose of dexa rather than dividing the doses into two. The reason being we don't want the circadian rhythm to be disturbed. That is one reason. You can give as a single dose 10 to 16 mg based on the weight of the child. Continue until any interventions are instituted, as well as try to see the management is dictated by the patient's trajectory again. Like we told, you can use opioids, you can use chemotherapy, radiotherapy, which is your forte, depending on the trajectory, and also look into removing of any catheter if it is related to IV thrombus or any anticoagulation. Also, whenever there is swelling in the hand and all, we avoid any IV lines on that side. That's something given in the practice, right? So that is about SCCO. Next, we'll be going to spinal cord compression by Mansi.
So there's one comment in the chat from Dr. Shruti saying that parents sometimes opt for ICU care in the face of emergency in spite of prior discussions, and we end admitting them to the ICU, especially if they present late in the evening. Yeah, absolutely. This is a very, very important point that you have raised. And this is exactly how we are, why we are trying to integrate the palliative team into the entire team of people who are handling a child, because if we definitely understand that if any parent is bringing their child to the ICU or to the casualty, they do expect that their treating physician does admit them. And it might be a very big spiritual or ethical dilemma for you as oncologists who have helped them through the years to be that face alone who needs to tell them that the goals need to be reframed. So that is where palliative care kind of steps in, because it tends to be, for example, at Vadia or at Tata, what we have is a joint committee meeting where the palliative team is early on introduced to these parents to make sure that they are now aware that their decisions and their goals will have to be under the management of both the teams, because where we can actually step in and remind them that this now is going to be more of risk or trouble rather than keeping their child safe. What used to be like the way they handled emergencies during treatment is not the same anymore. And actively at Vadia, we definitely have do not escalate orders or DNAR orders for our children, especially who are in advanced illness. But the flip side of this is that if you are trying to explain to a parent that their child is going to pass because of the cancer now or the malignancy, what is important is that you provide them that support. So home care plays a very important role in this, that if you are supporting them or sending them home and making sure that they don't come back, one is either you give them regular home care where the palliative team goes into their homes, making sure that the goals are aligned, that they're told multiple times that their child might be facing this, that by the time it actually happens, they have heard about it at least 2, 3 times or 10 times, that they know what comes ahead. Or the second flip side of this is that you provide them video support, remote support that way. Or the other option is to use the local physician that is present in the community to handle this. And I'll come to this spinal cord compression and talk about this a little more, because I don't want to go into too many details and I think we are pressed for time. But what I need to explain to you in spinal cord compression, and it's good that you have raised this point just before spinal cord compression, I will go directly to a story of our patient. This is Harsh. So everyone, this was a patient of hepatoblastoma and he developed spine mets. So when he went home, this is how he looked. And the mom was very, very sure, even on the first day, she had that very clear communication that was given by the oncology team as well as the palliative team, where they were explained that his hepatoblastoma has metastasized. It was a relapse. So we did not want to actually put Harsh through any more of hospital stay. And but this child lived 1.5 hours away into a remote village just on the outskirts of Mumbai. But there was regular home care that we could provide every 15 to 20 days. We were continuously in touch with the Hematonco team, just updating them about Harsh every now and then to make sure. And as Harsh progressed, there were multiple symptoms that we have been talking about through these slides and emergencies, which we have kept them here as an example. So it started with lung mets, it started with pleural effusion. Hers did develop dyspnea at one point. Morphine was added. There was oxygen support provided at home because he was feeling that he would be better when there's an oxygen mask on him, because he was so, mentally adapted to that. But in addition to that, there was bleeding because at one point he developed bed sores. He went into progressive spinal compression, and his spinal compression was something that was explained to the family at that point, and that's why they did not choose to ever admit him back into the hospital. But what was the flip side of this was that he had to be provided skin care. They had to be explained when his bladder function decreased. We went home to catheterize him. All his bowel interventions were kept to be as they are. Pain management was one of the main things that had to be done, especially when there was stretch pain. So we had started steroids when he went into acute compression, where, for example, when we are within that urgent window, we did try to give him dexamethasone. That did slow the process of his spinal cord compression. At one point, we did consider palliative RT, but the mom was very sure that she didn't want to put him through that whole cycle. So instead, dexamethasone was added, and then slowly, as his spinal cord compression progressed, he developed sensory loss completely. So these are some of the nuances. For example, he had ant bites at one stage, So these are some of the things that we have never accounted for, even as pediatricians or people from palliative background. And so we had to actually deal with his ant bites. There was bleeding from the bed sore at one point. So these are some of the things that we did at home. But what was important was that the family was at complete peace that whatever is being done is for the best interest of their child, and that they do not need to do anything more than that. And there were situations of panic in between, but they were handled because there was a team of psychologists and counselors and nurses, along with doctors, who were reiterating this message, which gave him a very peaceful death at home. And there is something that I want to add here, that we could make a book on Harsh, which we took to his home. We read it to him, we read it to his family. And that was the whole experience. So, what was going to be a very traumatic death for Harsh in the hospital, we would have definitely gone behind, tried to address his spinal cord compression. I don't know how much that would have increased quality of life or his capacities. And but what Harsh wanted was actual time to be spent at home. He wanted to visit the Shivaji Maharaj temple, so we arranged that for him. Instead, we made his family come to his home, spend time with him. Till the end, he kept asking for his favorite meals, which was something that was very dear to him. So it might sound very small when we discuss it this way, but for someone who's dying or at end of life, these are very important experiences. So when we went for bereavement support, which is very necessary, and at 1 month we went for bereavement support, and the mom actually, made us sit with the entire family. And she openly spoke that there were many times when she considered running back toward the hospital, but she knew that her child would end up in the ICU. There were things that the doctor would be obligated to do, which she could not avoid. So she took this leap, and she was very, very peaceful in spite of this child passing. And that is something that we have been trying to communicate or convey to you through this, that it might be difficult as oncologists to not act at spinal level, or to your reflexes of immediately managing these emergencies. But definitely when you look at the larger picture, or when children are on palliation or at end of life, do consider taking the palliative team along for reframing these goals of care, because reframing is needed not only for the family but also for us as physicians to not act on our impulse. And that is the main take home message that we want to give through this session. I will leave the last two slides to Dr. Ishaq, and then we will wrap up with some questions.
Thank you, Mansi. So those were the emergencies, and whenever the symptoms become refractory, so what do we do at those times? So at the initial start of the session, we did talk about what the various emergencies, right from pain to agitation to bleeding to spinal cord compression, etc. Right. So whenever the emergencies are too refractory to be treated, whenever the symptom is not something that can be taken control of, we have to look into usage of continuous infusion of either midas or an opioid infusion, depending on the kind of symptom it is. For example, if there is a child with terminal agitation, or if there is a child with terminal delirium, at those occasions we would need to go for this continuous infusions, which would either provide complete sedation for the child. Again, this has to be proportionate sedation depending on how much the suffering is. I have had patients where we had given them sedation for 8 to 10 hours and then removed the sedation, and they came out without any kind of symptoms. So you have to know what is the proportionate amount of sedation that you need to give, whether it has to be a persisting one or it has to be a breaked one. And again, this is something that can be used for any kind of refractory symptoms. And whenever you're going to do or go ahead with this, one thing you need to remember is you need to have a clear communication with the family that this is something that is going to be anticipated, and the best possible thing to do for comfort of the child would be for going for continuous infusion. And many times I have had my own healthcare providers who used to come and say, "Sir, is this ethical?" So when you actually look at it, ethical framework, when you're talking right from beneficence and non-maleficence, you're trying to see that the child is provided with the good symptom management. You're not looking at, okay, if you're giving sedation, maybe he's not going to have any oral feeds and all. The main thing would be to see that the child's suffering is reduced to the maximum amount. So ethically also, whenever you are coming with these kind of scenarios, sit with the team, see that you have a clear communication why you're doing something and why you are choosing a particular path for good symptom management. Next slide. And finally, the key message is whenever we are treating some emergencies, it is always good to have an anticipatory plan, whether it is through the palliative care team or to the oncology team. Try to have an anticipatory plan about some symptoms that are more common in a particular disease. Identify the children who are at high risk of these. Prepare an emergency care plan. Give them some rescue medication so that whenever there is some of these symptoms, immediate rapid symptom relief can be provided. And the most important goal throughout this is providing good symptom care comfort. And the comfort could also be even with the location of care. So try to see that it is managed at the best possible place where the family and patient is comfortable. Try to educate caregivers for home emergencies and also prepare teams in regards with reducing fear and trauma for families and staff. So these are some key messages that we take from here. I thank you all for your patient listening. Any questions, any thoughts for us so that we can have some discussion here? Any questions? I know this has been a long didactic session for all of you, but do you have any experiences that you would like to share, or maybe an ethical dilemma kind of a situation where you thought, okay, maybe you could have done something differently? Any thoughts?
Maybe that comment in the chat that Dr. Abhigyan has said, if he wants to speak more about it, or how bleeding is one of the most difficult ones, if you want to, or we can actually discuss.
Hi, ma'am. This is Dr. Anjana. I'm FNB fellow, second year. So, one dilemma I always had was since my first year, so many patients, right? We have a lot of patient load. We have about 60, 70 patients every day. So, a lot of patients go home on palliative care, but we do not really provide at home palliative care services. So, how detailed should be the anticipatory counseling to the parents? Like a child will have multiple ways of passing away, and parents keep asking me what can happen and explaining each different scenario to them. This all can happen, and the child might pass. Like I've seen the mother in so much pain while listening to it and like imagining it. These all can happen. It's very difficult. I'm very confused as to if I have to tell them, and if yes, then how, in what detail.
Ishak, you want to go first?
Yeah, I'll just answer in a short way that, for example, if you're looking at a child with leukemia, for example, and whenever, yes, it is very distressful for the family to hear all this. So whenever we give information, we give it in chunks and pieces. So that's why it is a lot more helpful if you have these conversations little prior to the stage where they're getting discharged. You can't have this conversation right at the day of discharge or a day prior. So still, if it is not possible, see that you give at least few symptoms. For example, if there's a child with ALL, seizure is something that can happen because of CNS disease. Most common thing would be pain crisis as well as bleeding, through which the child might pass away or have a very difficult end of life period. So if you can give them few symptoms and kind of give them information in terms of whenever these symptoms come, these medications can be used, is something that is helpful. And also, whenever you're having a conversation, try to ask them what is the most worrying thing for them to go home. Suppose when you say that, it actually opens a box for them where they can share their worries and put it forward in front of you so that you can provide them some solution. Because if you are not able to let them vocalize it, that worry stays with them. So that is one point I wanted to raise. Mansi, go ahead.
No, thank you. I was going to say the same thing. The only thing that is different, I wanted to say was that in palliative care, and when you are explaining to parents, yes, at the cost, I understand that you have a very long relationship with your parents and the child. And it is very difficult to suddenly get into those shoes and start talking about that because it might be perceived negatively by them. But the thing to keep in mind is that information at that point is actually key for them, and whatever reality that you are trying to get across to them is in their best interest. So the tone of the whole conversation is that I hope none of this happens. I hope and I wish that things could have been different, but unfortunately this is how it is going to be, and I want you to be well prepared for it. So be home care or not be home care, be there remote support or not remote support. What is necessary is that the parents feel that you have had the courage to actually speak to them about all these things. So like Dr. Ishak said, it can be in chunks. Suppose you want to invite them again after that first news is broken. Maybe another follow-up conversation on the phone can be one of the options. Another option is to use video calls. We used to do them from Tata when we were there. Or you can also if they are going to end up in your hospital and you are anticipating that there's going to be a hospital death, then please rely on documentation of do not escalate orders. Think about those conversations well in advance, because now, today, if a child of relapsed ALL comes in the casualty, and Dr. Isha can add to this, we know that there'll be a certain amount of escalation, but we'll also know that parents will not choose few of the things that will follow. And that's something that is very, very important for them for that advanced care planning. Yeah.
Yeah. Thanks for bringing that question in regards. Any other thoughts?
most often oncologists also feel that it's like wearing another hat for you all, but it's actually not a different hat. You're just progressing into a role now, where you are not really giving up on your child. It must be hurting deeply to think of it that way, but what you can do is that if the child is going to pass now, and if death is going to be imminent, then why not be that person who will help them die peacefully or comfortably? So for that, if you have to go through this experience, it might be worth it. And do involve the palliative team as much as possible for this situation.
Yes, care and comfort.
And one more thing is that do have bereavement visits for your patients, when you will understand that when the child has passed, see them talk about that experience. That is the most useful experience that I feel in palliative care, is to understand later on what went well and what did not go well. So from their stories itself, you will understand that this was helpful, that you spoke to them this way, that this was discussed, and what was not useful will automatically be told to you, that they did not have enough of this could not have gone the way it went. So these are very important. Just see if you can do some of the bereavement visits with your parents. That's a very good learning experience for everyone.
Yes, ma'am. Actually, I've had the opportunity to do a study on this.
Oh,
The
great.
choice of place of death as chosen
Hmm.
by parents, is it hospital or home, which was best and why? It was, I mean, both were, a lot of parents did complain about pain and they were not able to watch the child pass at
Hmm.
home. But then a lot of them also complained in the hospital, okay, we had a lot of medication, the child was in the ICU and all that. But this was way back in my MD. We did not have a
Okay.
palliative care team. Now we have
Let's
a
try to
palliative care team. Yes, yes.
maybe we should try to do that study again and see how it compares to what happened now. Yeah,
Yes,
lovely to
yes.
hear about that. Great.
And what would be the best placement? Like, what if we do have in-house in hospital palliative care? Like, do we
Yes.
still counsel the parents to
Huh.
stay back or send them home and maybe?
So, ideally, if there is a hospice, which we don't have, at least in Mumbai, we don't have that situation where we can put the child for a few days in the hospice for active dying. But
Mm-hmm.
what we have provided in Vadia, at least, or in Tata, is a space where we are not keeping them in the general ward. We are not escalating to ICU, but we are keeping them in a private room. And that private room for that patient is made free by the management. And we of course, it was a big journey for Dr. Veronic to arrange all this. But yes, whenever a child is actively dying and the parents prefer to let the child pass in the hospital, then it's in that room, providing minimal oxygen. Of course, pain management and all continues. And this active acts of holding the child, keeping them on their chest, all these things are done there, including memory making. And these are some of the finer things that go along hospital death. So it's not, there's no right answer to either of
Correct.
them. Yeah,
Correct. Thank you. We have a long way to go.
yeah, definitely. Vinila, Dr. Ishak, you want to say some final remarks or?
No, it was great to hear from you all regards your experiences, and thanks for bringing up some questions. We had a comment from Dr. Muniba. Thanks for improving our therapeutic relation with end-of-life patient and their parents. Thank you, Dr. Muniba, for the comment. I thank you all. It was. I hope we kind of imparted some knowledge in terms of some symptom management and bringing some different perspective to what we can do, all as a team, basically. Right from support from palliative care team to oncology team to all the other departments and all the other allied healthcare professionals as well. Thank you. Thanks for your patient listening. Thank you, Mansi,
Yeah.
for helping us with the slides and delivering the talk, and also for clearing the questions. Any thoughts, last thoughts, or we can end it?
No, thank you all. It was a very wonderful experience. I was really fearing talking to so many oncologists, but I realized that we are just looking at patient comfort together, and there's a lot of teamwork that can go across. So feel free to reach out at any point, and yeah, we'll send some reading materials if at all necessary. So yeah, thank you all for your patience. Thank you, Ishak.
Yeah.
Thank you.
Thank
all.
you, everyone.
Bye-bye.
Thank you, Dr. Mansi and Dr. Ishad. That was really
Thank you,
wonderful. And
Veneela.
I would like
Thanks
to
for the
thank
technical
Dr. Veronique
support.
and Dr. Manas also for joining today's session. I request all the faculty and the candidates, I request all the participants to please share your post-test and feedback, which is mandate, and we will come back to you. And our next session will be on 6th March, and again Friday, and 3 more to go. So here the countdown starts. Thank you so much. Thank you, everyone. Good
Thank you,
night.
Vinila, best person of the most important person on the call. Thank you very much for
Thank you.
Veneela,
Thank you,
for the
everyone.
technical support, like
Yeah.
always.
Bye.
Yes. Bye.
Thank
Good
you.
night.
Bye.